Welcome to week 4, and what we're doing this week is continuing with the abdomen. We touched on abdomen last week, and we're just going mainly the anatomy we focused on, and so now we're going to focus more on the pathologies specific to each blood vessels. So we're going to start with the thoracic aorta. And so just some little fun facts that you need to know is that the normal aortic valve area is 2.5 to 3.5 centimeters square. So this area here should be 2.5 to 3.5. The ascending thoracic aorta, which is from the aortic valve to the first major branch of the arch, to the brachiocephalic, that diameter is usually, again, 2.5 to 3.5. The actual transverse and descending thoracic aorta, so this area here, all of this is about 2.5 centimeters in diameter. The thoracic aorta presents more challenges. A lot of times diseases of the thoracic aorta are treated surgically. Now, more and more as techniques and technologies advance, they're doing more of these types of stent grafts with all of these branches. And if it's distal, if it's just localized to this area, distal to the arch, but before the diaphragm, then they can treat that with a stent graft easy enough. But it's when it gets into all of these branches is when the problem occurs. So a lot of times these are still treated surgically, but more and more, as like I said, as technology advances, they're being treated with stent grafts or endografts. So again, the pathologies: aneurysms, dissection. Those are degenerative etiology associated with aging, atherosclerosis, the accumulation of plaque. One exception noteworthy is the coarctation. Remember, that is a congenital narrowing. It's present at birth. Again, no rhyme or reason to it, just occurs in some infants. A lot of times goes unnoticed for many, many years, and then later in life it starts to cause problems. And then at that time it needs to be repaired. So the aorta tends to get smaller and smaller as it descends down the body. So at the diaphragm, it's at about 1.2, I'm sorry, 1.5 to 2 centimeters in diameter. And then below the renals, or infrarenal, it's the normal diameter is about 1.5 centimeters. So again, it just kind of gets smaller as it descends. Again, lots of things can happen to this abdominal aorta. Seems like the most common being a AAA, an abdominal aortic aneurysm. Again, associated with atherosclerosis, and it's interesting or important to note that these aneurysms tend to always affect the iliac arteries as well, and so these types of stent grafts here that go from infrarenal to above the bifurcation are not as common, just simply because the iliacs are usually involved as well. And so it's this type of stent graft that is mostly the time placed. Of course, there are some other pathologies that can cause an aneurysm, and we talked about some of those in the pathology section. They could have just an underlying disorder like Marfan syndrome, or they could have some kind of trauma or some sort of inflammation. Repair of the abdominal aneurysm occurs when the diameter exceeds 5.5 centimeters. So greater than 5.5 centimeters is when repair needs to be done. I can't write, but that says repair. One term that may need to be introduced is claudication. Claudication is the term for pain or cramping in the legs when walking. That is, again, caused by atherosclerosis, which is an occlusive type disease. Treatment for that is angioplasty and stent. Again, we've got the abdominal aorta could have an embolic occlusion, meaning a thrombus from somewhere else travels to the distal the distal aorta and causes a blockage. The abdominal aortic can form a dissection. Let me back up for a minute. Before we just talk about dissection, I want to talk about the occlusive disease or the embolic occlusion. When there's an occlusion of the abdominal aorta, sometimes the patient has to have bypass surgery for treatment. And so here are some examples of some bypass surgeries. So here is an example of axillary femoral bypass. So apparently the occlusion looks to be in the lower thoracic aorta, wherever it is. This graft has been sewn into the axillary artery, and then the distal end is sewn into the femoral artery. So that's an axillary femoral bypass. Here is another type of bypass. It looks like it's going from the aorta to the femoral arteries, and then here's a femoral to femoral bypass. So now again, these are surgeries, so these aren't done in the interventional department. However, there will be times where you do an angiography on these bypass grafts because again there's occlusion, and so you need to treat that. So these are some different bypass surgeries that you might encounter. Here's another picture. This is a good picture, a CT showing that graft. This is an axillary femoral, and so just kind of interesting to see how they tunnel that graft under the subcutaneous tissue. And then here is a femoral to femoral bypass graft. So again, just interesting how they do that, and what you might see. Okay, now back to the aortic dissection. Usually if there's a dissection in the abdominal aorta, it's an extension of the thoracic aorta dissection, or it could be iatrogenic, caused by a physician during a procedure. And what's important about dissections is that retrograde dissections are usually not treated because the normal blood flow will just heal it. And so what that means is if there was a dissection going up this way, then the normal blood flow would just push that flap down flat and it would just heal itself. Whereas an antegrade dissection is more troublesome, and this is what this picture is demonstrating, an antegrade dissection. So here, this is an antegrade dissection, and so now when the blood is flowing antegrade, which is the normal flow, that flow will go into that false lumen and make the dissection, or make that false lumen bigger and bigger, and it'll just continue to grow. So it's important. So again, it's important to note that the antegrade dissections are more troublesome than retrograde dissections. So the treatment for this is to place a stent graft over the entry tear. So it's only necessary to put a stent graft right here where the tear is, and then that false lumen over time will eventually just absorb.